Dear ESTS members and webinar attendees, my name is Lieven de Piepere, your ESTS webinar coordinator and the moderator for today. And this is the 5th webinar of the 2019-2020 series. Today will be about the management of malignant pleural effusions with over 200 online subscriptions right now. Therefore, I'm very proud to introduce you to Professor Clemens Aigner as a guest speaker. Professor Aigner is the head of the Department of Thoracic Surgery and Surgical Endoscopy of the University Hospital Ruhrland Clinic in Essen, and he's Professor of Thoracic Surgery at the University of Duisburg-Essen. He has received many awards and prizes for his clinical and experimental work, and he's currently the co-director of the West German Lung Cancer Center and also the co-director of the West German Cancer Center. So, therefore, I think he's the ideal speaker to talk to us about this malignant pleural effusions today. Professor Aigner, the stage is yours.
Thank you very much for the kind introduction. It's a pleasure to be here and to talk about management of malignant pleural effusions. Actually, malignant pleural effusions is something every one of us frequently encounters in daily practice. And I'm just trying to enable the screen sharing now. Okay, I think it works now. So,
yeah, you can just put it in your slides on the full screen.
Okay, now there we go.
Perfect. Yeah, thank you.
So, basically, I'm going to structure my talk first of all about the basics and the diagnosis of malignant pleural effusion, then talk a little about the etiology of the effusions and what kind of guidelines we have available currently, talk about some recent clinical studies which shed light on some details aspects in the management of malignant pleural effusion, and then try to show you something with what you can do with translational research with aspect to malignant pleural effusions. So whenever there are some questions, you're free to come up, of course. Every one of us knows that the pleural fluid production is certainly less usually than the pleural fluid absorption capacity of the pleura. So actually the pleura is able to absorb roughly in an average adult person around 250 to 450 milliliters per day. And normally there's a balance between production and resorption. So in cases of tumor situations, there's a disbalance which leads to the development of malignant pleural effusions. There can be increased capillary permeability due to tumor implants, due to inflammation in the pleural space. There can be an increased hydrostatic pressure or a decreased oncotic pressure, for example, due to hyperalbuminemia, or an increased negative intrapleural pressure due to atelectasis or a trapped lung. There can be decreased lymphatic drainage due to obstruction by the tumor or by some predescent radiotherapy, or there can be, for example, vascular obstruction like in the superior vena cava syndrome or just plain chylothorax. It's important to manage that not all of these processes, which can occur in patients with malignant disease, necessarily directly lead to the development of malignant pleural effusion, but these patients can also develop benign pleural effusion due to an underlying malignant disease. This is important to differentiate also with regard to the management of these patients. I think I don't need to spend much time talking about basic diagnostic examinations of the pleural fluid, which can differentiate, transudate, exudate, and the underlying cause of the effusion. These are pretty much standardized, like total protein, LDH, specific weight, cytology, microbiology, and so on. Basically, the most important differentiation probably when a patient presents with pleural effusion and an underlying malignant disease is to differentiate whether the effusion is malignant or benign. There are, of course, several other aspects which need to be taken into account when talking about the management of pleural effusion. It's important whether the effusion is unilateral or bilateral, whether the lung is expanded or whether there's a trapped lung situation. Of course, it is very important to know what life expectancy the patient has, how compliant the patient is with regard to management, and what other comorbidities are present. So the first step when a patient presents with pleural effusion is always to establish a diagnosis. There are several options available. You can do a cytology by thoracocentesis, puncture, or drainage, which actually has a sensitivity only of 40 to 65% depending on the study. In patients with malignant pleural mesothelioma, the sensitivity even goes down to 25%. You have the option of percutaneous needle biopsy, which has a sensitivity of around 45%. In patients with MPM, only around 20%. And you have the option of thoracoscopy, which has the highest sensitivity of 85 to 98% in patients basically with all types of effusions. So even if a thoracocentesis or a drainage might be justified upon the first development of pleural effusion as a diagnostic test, it has been shown by several studies that actually in patients who develop a recurrent pleural effusion, definitely a definitive procedure is associated with fewer subsequent procedures and also fewer complications. So thoracoscopy should be done very early on in the diagnostic procedure to obtain optimal sensitivity, and in patients with recurrent pleural effusion, some kind of definitive treatment strategy should be considered. What options do we have in patients with recurrent pleural effusion to treat this effusion locally? Of course, there's always in a patient with a malignant disease, the systemic treatment of an underlying disease is an important issue. But for local treatment, there's the thoracocentesis or the drainage as a temporary procedure. And for definitive procedures, we have available pleurodesis. We have the option of indwelling pleural catheters, or we have the option of pleuroperitoneal or pleurovenous shunting. Pleuroperitoneal and pleurovenous shunting are in patients with malignant pleural effusion where malignant cells are present, considered to be with some caution, particularly in patients who have a longer life expectancy due to the potential re-infusion of malignant cells. So I would be interested in the current practice of the audience. What is sort of standard management in patients who have a bilateral recurrent malignant pleural effusion with fully expandable lungs and a reasonably good life expectancy, what the preferred treatment is. Is it bilateral talc pleurodesis? Is it bilateral indwelling pleural catheter? Is it on one side a pleurodesis and on the other side a catheter? Or is it either pleurovenous or pleuroperitoneal shunting bilaterally, or are there some other options available? I think this question covers a couple of topics which I'm going to address later in the talk. So I would really be interested in the answer. And the poll is open now on the right side of your screen.
Yeah, so for the audience, if you go to your right sidebar, you have questions, polls, and people. And in the middle one, polls, if you click on polls, the poll is available. You can vote. The more people vote, the more we're sure about the current practice. So please do so. It's anonymous. You cannot know who did what. But if you have any comments on it, you can post them in questions, and then we can ask to Professor Aigner to comment on that. But right now, please make your vote on one of these possibilities.
Okay, so what I'm seeing so far, the vast majority opts for bilateral talc pleurodesis. There are some bilateral indwelling pleural catheters, and 12% one-side talc pleurodesis, one-side catheter. Okay, that's interesting starting point. Now let's see a little further what the guidelines tell us and what options are available. So thoracentesis, you know, we have a lot of different systems available. We have a lot of different drainages open. The drainage size is something which has been looked into. We have the option of pleurodesis, where talc is the established best sclerosant agent, and there's the possibility of either talc poudrage, usually done by a thoracoscopy, or the option of talc slurry, which can also be installed just by drainage without any thoracoscopy. And there's the option of indwelling pleural catheters, which are usually implanted anteriorly by a tunneled way and available by several manufacturers. So first, when we're talking about pleural effusions, it's important to know whether we have a primary pleural malignancy or a secondary pleural malignancy. The primary pleural malignancies, particularly malignant pleural mesothelioma, are of course managed in a completely other way than a secondary pleural effusion, where the main underlying disease is lung cancer, followed by breast cancer, and several other tumors like lymphoma, gastrointestinal tumors, gynecological or urological tumors, sarcomas, or others, or in some cases even a cancer of unknown primary. I'm not going to talk about the surgical options in malignant pleural mesothelioma. This would be a talk in itself, but I want to focus a little bit on what the guidelines tell us about the management of malignant pleural effusion in mesothelioma patients. There are several guidelines actually who address this issue. The most recent one, which is not yet published in paper, but was presented at the last ERS meeting. And this actually comes from the ESTS and recommends talc poudrage via thoracoscopy to control a recurrent MPM effusion as the first choice to achieve pleurodesis in patients with expanded lungs. And the palliative VATS partial pleurectomy for selected patients fit enough to undergo surgery to obtain pleural effusion control in symptomatic patients who cannot benefit from pleurodesis or indwelling catheter. Actually, what all the other guidelines also have in common is mainly that pleurodesis is recommended as the first line procedure, particularly in patients who are candidates for cytoreduction. If you look at the ESCO guideline, for example, it specifically mentions, interestingly, that tunneled pleural catheters are not recommended in patients who are candidates for maximal surgical cytoreduction because of the risk of tumor implantation into the chest wall. This is, for example, something which is a bit contradicted to our experience, because we frequently place tunneled pleural catheters also in patients with malignant pleural mesothelioma who are candidates for surgical cytoreduction by usually extended pleurectomy decortication. And if the tunneled pleural catheter is really placed exactly in the line of the thoracotomy afterwards and just by a short tunnel, the implantation rate is not really higher compared to what's seen in the pleurodesis, and the EPD pleurectomy decortication is, in my experience, sometimes easier after a pleurix catheter compared to a pleurodesis. But definitely the recommendation of the ESCO guidelines is what it says here. The British Society also recommend either talc via slurry poudrage or indwelling pleural catheters, both as options. And VATS partial pleurectomy is definitely an inferior option in these guidelines, and the ERS, the old ERS ESTS guidelines also recommended pleurodesis rather early in the disease process. So, but the majority of guidelines and the majority of patients with malignant pleural effusion, of course, present with effusions secondary, which metastasize secondary in the pleura by some extrapleural tumors. And there's actually quite a variability in the guidelines, and it has been analyzed a couple of years ago also by the ESTS. And the guidelines actually who achieved the highest degree 2 scores were most likely to come from the European societies with direct involvement of scientific societies. So I want to give you a little bit of an overview what these guidelines tell us. First of all, there's the ERS-EX guidelines from 2018, which says that both talc pleurodesis and indwelling pleural catheters effectively manage the symptoms of malignant pleural effusion. There was limited evidence regarding the management of trapped lung or loculated malignant pleural effusion. And this is a guideline which also implements a prognostic score, the so-called LENT score, which is a validated tool for predicting survival in patients with malignant pleural effusion. And this is something, an aspect which is very important in those patients to judge how long these patients are going to live. Then this guideline states that the PRIMS prognostic score demonstrates utility in mesothelioma prognostication, and there was no evidence to support the use of local oncological therapies as an alternative to drainage. And tissue biopsy apparently is the gold standard for diagnosis and treatment planning. Just to show you the LENT score, which is mentioned in the guidelines, it's basically based on, based on the pleural fluid LDH level, the ECOG performance score, the neutrophil lymphocyte ratio, and the underlying tumor type. And based on these parameters, patients are categorized into 3 categories, which show a prognostic differentiation between the groups. The PRIMS score does the same for the mesothelioma. It has been developed by Australians in Australia, and this guideline also states a variety of immunohistochemical markers which can differentiate different tumor types within the malignant pleural effusions. So there's another guideline from North America, from the ATS, STS, and STR. And basically, the recommendations of these guidelines are to use ultrasound to guide the pleural interventions, not to perform pleural interventions in asymptomatic patients with malignant pleural effusion. So basically, the interventions are for symptom control, and either an indwelling pleural catheter or chemical pleurodesis is recommended in symptomatic patients with malignant pleural effusion and suspected expandable lung. It is recommended to perform a large volume thoracentesis initially to assess the symptomatic response and lung expansion and decide whether further treatment is indicated. They recommend either to use talc poudrage or talc slurry for chemical pleurodesis, and in non-expandable lung, definitely indwelling pleural catheters. And one thing that's also important, if there's an indwelling pleural catheter placed, if there's an infection, this should primarily be treated with antibiotics and not necessarily an indication to immediately remove the catheter. There's a decision tree that in patients with known or suspected malignant pleural effusion, only symptomatic patients should be treated. First, this large volume thoracentesis. If there's an improvement in dyspnea and lung re-expansion, then the life expectancy is very important to assess, and if there's an expansion, either indwelling pleural catheter or pleurodesis can be used, talcum poudrage or talc slurry. And in patients who do not have a lung expansion, only if a very short survival period is anticipated, then a repeated thoracentesis can be performed. if life expectancy is long enough, then definitely indwelling pleural catheter should be placed, and probably until the lung re-expands. So this is an overview of current guidelines. This is certainly not all guidelines covered. There's another guidelines from the British Society and some older guidelines, but I'll try to give you an overview of the newer guidelines. So basically, when we're talking about talc pleurodesis, what recent studies do we have available? There's a very recent publication in the JAMA, actually from this year, who assessed the effect of thoracoscopic talc brouillage versus talc slurry. It was actually done by medical thoracoscopy versus talc slurry via chest tube on the pleurodesis failure rate among patients with malignant pleural effusion. And actually, this study interestingly showed that no significant difference between the two methods of talc application. So the failure rate here in the early stages was a bit higher with talc slurry, but after 180 days, which was the primary endpoint, there was no significant difference, neither 90 days. This is recent result of a randomized study, which is probably a bit contradictory to the experience to some of us, but that's to date now the best evidence available. There was actually already a couple of years ago the so-called Time 1 randomized clinical trial, which assessed the effects of opioids versus non-steroidal anti-inflammatory drugs and the size of the chest tube, and actually showed that the use of NSAIDs did not lead to a decreased pleurodesis efficacy, but actually the use of the smaller chest drains actually led to a inferior pleurodesis efficacy. The rate was 30% versus 24% failure rate. Not that much, but definitely something to keep in mind. One very interesting finding was published just recently in the lung cancer, which actually used the cohort of the just before mentioned Time 1 clinical trial and demonstrated that those patients who had a successful pleurodesis actually showed a superior survival compared to those patients who had a failure of the pleurodesis. This was actually validated in a second data set from Oxford with the same result. The underlying reasons for this are not entirely clear, but it's definitely a very interesting finding in my opinion. So what recent studies are available for indwelling pleural catheters? Before we start with this, I'd like to ask you another question, and would be very interesting for me to know in patients with indwelling pleural catheters, if the lung expands fully after the implementation, what's the drainage frequency? Is it done daily? Is it just done every second or third day? Or is it purely symptom guided? Or do you have any complete other type of management? So please vote now.
People are voting. Mm-hmm. In the meanwhile, we already have one question, but maybe we come back on that later.
I think we can discuss this at the end.
Oh, okay.
Probably together. So it's almost an even balance, a bit more symptom guided and daily, and the minority every second or third day. Okay, so let me show you what some recent studies say on this topic. Actually, it has been demonstrated already a couple of years ago that indwelling pleural catheters are basically comparable to talc pleurodesis at relieving patient-reported dyspnea and can be used in a comparable way and in a comparable setting also to talc pleurodesis. There was another prospective randomized trial published 3 years ago, and actually both treatment options, indwelling pleural catheters, pleurodesis, showed same results with regard to dyspnea scores. There were some secondary endpoints which favored indwelling pleural catheters, but the conclusion of this study is that actually patients should be unable to choose either treatment if a malignant pleural effusion occurs. One thing that's very interesting and has not so long ago been published in the Respiratory Medicine is the AMPLE-2 trial, which showed that aggressive daily drainage of the indwelling pleural catheters compared to symptom-guided drainage only led to a significantly higher pleurodesis rate early on in those patients, and thus actually showed to be more effective and also has the potential to lead to an earlier catheter removal compared to symptom-guided drainage only. This has been confirmed by another study which was published already 3 years ago in the Blue Journal, which also demonstrated that daily drainage of the pleural fluid led to higher rate of autopleurodesis and faster time to liberty from the catheter. Another study which was recently published in the New England is actually has demonstrated that in patients who receive a pleural catheter and the lung is expanded after 10 days and thereafter randomization was done between 4 grams of talc slurry via the drainage or placebo, those patients had a significantly higher rate of successful pleurodesis compared to those patients who only had placebo inserted via their catheters. The use of urokinase in patients with non-expanded lung or non-draining malignant pleural effusion did not show any additional beneficial effect and actually does not have a role currently. Another issue is always the cost effectiveness, and there was a secondary analysis of the time 2 trial I've shown before, and these calculations actually showed that pleural catheters were cost effective with regard to compared to talc pleurodesis. However, the longer the period drainage is required, of course, the less likely this cost effectiveness is still present. There are several other studies ongoing with regard to the management of malignant pleural effusions. I won't go into all the details of that, but a nice summary of these studies has been published last year in the Lancet Respiratory Medicine, which also showed a sort of summary of the management of malignant pleural effusions. It's again, improvement in dyspnea is an important issue to be eligible for treatment. If lung re-expansion occurs, then either indwelling pleural catheters or talc pleurodesis are options. If the lung does not re-expand, indwelling pleural catheters are the option of choice. So much for the current clinical studies. And I just want to give you, before we come to this discussion, a brief overview what can be done in patients with malignant pleural effusion to also achieve some advances in the management of these patients, and what translational research options originate from patients with malignant pleural effusion. We've established actually a pleural effusion biobank starting from July 2016 on, and have preserved now pleural effusion samples from basically every patient intraoperatively where we encounter pleural effusion. In total, we have 801 patients with cryopreserved cellular and soluble fractions. We were able to develop a lot of new tumor cell lines and also patient-derived xenografts models. So this is actually the numbers of the patients with effusions. You can see those patients here with the red and the gray bar are the total number of patients with some underlying malignant disease where just a percentage actually has malignant pleural effusion and the rest have benign effusion where no malignant cells are present in the effusion, even though an underlying oncological disease is the reason for the effusion, and the rest is benign pleural effusions. The majority of the malignant pleural effusions originate from lung cancer, a lot from mesothelioma patients and some other underlying diseases, which are shown here. And actually, I want to give you one example for primary pleural malignancy and one for non-primary pleural malignancy, what can be done with these patients. For example, we looked into TGF-beta as a diagnostic biomarker in malignant pleural mesothelioma, and you can see that the TGF-beta pleural effusion levels were significantly higher in MPM patients compared to non-malignant pleural disease, with a nice area under the curve. This was actually true for epithelioid and non-epithelioid type patients, and was also able to differentiate MPM from lung cancer patients. In the SMRP in the peripheral blood, which is the best available biomarker so far, actually the area under the curve is not so much different, and this is also able to differentiate epithelioid from non-epithelioid or positive only in epithelioid patients. It was actually also in our cohort prognostic in patients with epithelioid with a cutoff of 11.25. In non-epithelioid, this was not significant. The levels were quite higher, and the curves separate even larger compared to mesothelin in the peripheral blood. Another nice example is that actually from these pleural effusion, cell lines can be established from various underlying tumors, and it's really live cell lines where also some resistance testing is possible, and we were able to establish PDX models from subcutaneous tissue in mice as well as intrapleural implantations. And another example which I think highlights the importance also of surgical rebiopsies in patients who have a long history of treatment of oncologic diseases, like in this 38-year-old female patient who initially underwent chemoradiation for her pulmonary adenocarcinoma, then crizotinib therapy, then developed resistance and underwent video thoracoscopic biopsies. We were able to not only show some interesting histological features like the epithelial to mesenchymal transition in the course from the initial diagnosis to the development of the resistance, but also by taking biopsies from different sites at the same time point in the same patients, we're able to show that there are different mutations present actually in the same patient, highlighting the importance of sufficient tissue biopsies and the biopsy of also different sites. And we were able to establish different cell lines from these patients which also showed different sensitivity to ALK inhibitors in the distinct metastatic clones. So this is something which for the treatment of stage 4 patients I think is very important and underlines the importance of also taking sufficient, preferably surgical rebiopsies in these patients. Actually, we also were able to show that HDAC inhibitors were restoring the ALK inhibitor sensitivity in these cell lines, and also in the PDX models, those cell lines showed different growth activity. So this is just to show you that pleural effusions are actually excellent sources of biomarkers and tumor materials, and really can lead to the development of new in vivo and in vitro preclinical models and reanalysis of recurrent and metastatic tumors is a very important issue. We have an excellent translational research team also in our department who is doing all the work of this. And now to come to a summary of malignant pleural effusions, actually lung expansion is an important issue. Symptom improvement of the patient is the goal of the treatment. If patients have a trapped lung, indwelling pleural catheters are an option. If patients have an expanded lung, either TALC or indwelling pleural catheters are an option. And actually, I'm a bit hesitant with regard to bilateral TALC pleurodesis, which has been recommended by the majority. It's particularly in one operation, if a patient has bilateral effusions. TALC pleurodesis can lead to substantial respiratory insufficiency if it's done bilateral, which I've experienced in a few patients. That's why I'm very hesitant to recommend this. And also in the stage procedure, it has to be done with some cautions. So to give you some personal recommendations, IPC and TALC are both appropriate in patients with expanded lung. All the above issues mentioned before have to be taken into account. I would strongly recommend to avoid bilateral TALC pleurodesis in one operation, and also be careful with stage bilateral TALC pleurodesis. In some patients who have partially trapped lung, actually the combination of TALC bouturage in the expanded parts and IPC insertion in the trapped part is certainly an option. In case of highly trapped lung, catheters are the treatment of choice. If you insert the catheter early on, an increased drainage frequency is important to facilitate pleurodesis, and of course you have to check regularly for the possibility of catheter removal. And of course further developments are warranted, and particularly in patients with benign pleural effusions, also probably to some underlying malignant disease, internal drainage definitely is an option which would be very favorable to have in. So I'd like to thank you very much for your attention for now, and look forward to the discussion now.
Okay, thank you very much for this very nice talk, and also a very nice overview of the possibilities we can have to do translational research on this kind of topic. Thank you very much. Do you want to comment on the two questions? I think the first one you already did. So the bilateral TALC pleurodesis, you're not a big fan. Does this have to do with the calibrated TALC or not calibrated TALC, or is it something you have seen in each of them? Personally, I didn't see this respiratory problems in just using French TALC or the calibrated TALC, but I don't know what your experience is.
Well, we're also using French TALC. It's only graded TALC with particle size usually around 25 micrometers. This is very important to use to avoid embolism of small talc particles. But nevertheless, the talc is some sort of can lead to some sort of impairment, and I've had probably was just bad luck. It's not a high number of patients, but it was a couple of patients who had a bilateral talc pleurodesis and really developed some massive respiratory distress symptoms. There was no signs of any embolism to be found, but it was really just to the reaction to the local reaction on the talc pleurodesis. It's not so much an issue if it's done in a staged procedure, but you carefully have to check for the lung function of the patient, and particularly for signs of restrictive disease. Basically, the pleural catheters are in those patients with bilateral effusions really a very nice option, and you always have the, actually we see with this increased drainage frequency in the early part, a rather high rate of pleural disease, and in the majority of patients actually the catheters can be removed again, so it's a very nice option for bilateral patients, for patients with bilateral effusions, in my opinion.
Well, the problem in our country, for instance, is that the pleural catheters, the patients have to buy them themselves, while the TALC pleurodesis procedure is completely reimbursed. So this is something to keep in mind for the patient. Also, it is about 1,000 euros for a catheter for this patient.
In this case, I fully understand that it's difficult. So, of course, the reimbursement policy is a very important issue. With us, the catheters and also the bottles to drain are fully reimbursed. So, actually, for the patient, it doesn't make any difference. But I fully understand that if this is not reimbursed by a system, that this is a major hindrance for the patient, apparently.
Any recommendations on the how many grams you use in one side of pleurodesis and the pudridge? Do you use 3, 4, 5 grams of talc?
Well, we usually use 3-gram bottles of talc. If there's a nice distribution, that's sufficient. Sometimes, if particularly in large chest cavities, we use a second one and go up to 5 grams max. This is actually also what the recommendations say. It's in between 2 to 5 grams of talc.
Okay, because I can also yeah.
Sorry, I can see there are a couple of questions.
Yeah, we'll start with these. I just gave the audience some time to pose the questions. Where do you want to start? Maybe the first one, the pleuropericardial window. Any technical advices for a young surgeon? And I think the next one is from the same person. If we have a bilateral malignant pleural effusion associated with a recurrent pericardial effusion, what will be the strategic or the management strategy? Any comments on that?
Okay, I mean, for a pleuropericardial window, it's a video thoracoscopic procedure, and it of course depends a bit on how much effusion there is in the pericardium, but usually it's advisable if you have a grasper to lift up the pericardium somewhat, and then I'm personally using an electrocautery hook. Just go above the level of or anterior to the level of the phrenic nerve and excise window of roughly 1 to 2 square centimeters. Basically, you're of course free to use any other technical device, but a hook and just a standard electrocautery is, I think, the most appropriate choice. Usually those patients, if they are stable enough and tolerate lateral positioning, that's definitely what I would recommend for the surgery. If a patient really is unstable and positioning is troublesome, it can also be done in just a normal position while lying on the back. If a bilateral effusion is associated with pericardial effusion as well, of course, what's usually most limiting for the patient with regard to the hemodynamic situation, so intraoperatively, is the pericardial effusion. So you definitely have to go for drainage of the pericardium from the first side where you start your operation. You can actually do this to the right side as well to the left side. It's possible from both sides. It depends a bit on the amount of pleural effusion inside the cavities and the degree of adhesions or what sort of adhesions between the pericardium and the lung you can expect. So I don't really have a clear recommendation what's better, left or right. So I would go for the side with the most effusion in the pleural cavity. If there are no major adhesions present, drain the pericardium into this side and put an indwelling pleural catheter probably in. You definitely should not use a talc pleurodesis on the side where you're draining the pericardium into, because then you're counteracting your pericardial pleural window. And then you can relieve the contralateral side. So I definitely think there is a role for surgery in the palliative management of these patients. The next question I'm seeing here, is there a place for EPP in malignant pleural effusion? Well, it's in a highly selected minority of patients with adenocarcinoma who develop malignant pleural disease very early on with a low tumor load, with negative mediastinum, with no other evidence of peripheral disease, with an excellent performance status, with an excellent functional capacity. And EPP can be an option in these patients. It's a highly selected patient group. There's, of course, not much evidence about this around, so it's a very individualized decision. And in my opinion, this should be done only after a neoadjuvant systemic treatment has been given, where the tumor shows a nice response, definitely is not progressive. Then an EPP can be considered in these patients. But really, that's a very highly selected patient group.
Then you recommend a talc procedure before surgical treatment for malignant pleural mesothelioma. I think we've had this, huh?
We've had this, yeah. Actually, if I'm planning an EPD, so extended pleurectomy decortication, which is the routine treatment for malignant pleural mesothelioma in our department, I think drainage by an indwelling pleural catheter, even though it's not the guidelines, is a very valid option, since it makes the decortication easier, in my opinion, sometimes. If there's an EPP planned due to massive tumor ingrowth into the lung, talc pleurodesis is actually an option which facilitates that section on the parietal side of the pleura. It is also feasible in EPD patients, but in my experience, sometimes it makes the operation a bit trickier compared otherwise. So in EPD, I would not necessarily recommend it routinely.
Okay.
The role of intraoperative chemotherapy. Well, it's actually, there's some papers on hypothermic introthoracic chemotherapy in patients with malignant pleural mesothelioma from the Sugar-Baker group, which was one of the first papers, and also from several centers in Germany, reporting on reasonable outcomes by adding HITOC as a local therapy on top of macroscopic complete resection, but there's definitely no final proof evidence that this has any additional value compared to other local treatment options. There's also in MPM patients, for example, some papers out on photodynamic therapy. There's the paper even talking about betadine at the end of the operation. So basically, the true role of these additional treatments is not fully clear. There's also recently from Zurich this paper on chemotherapy via a fibrin carrier. So there are, from the concept, there's logic behind it, after some microscopic radical resection, to add some local therapy to actually attack address the potentially remaining cells. but the proof is not yet there. So I think it's important to prospectively collect data, either by entering these patients into prospective registries or doing prospective trials to really validate the value of this. Actually, we're also doing HITOC now routinely at the end of our mesothelioma operations, and prospectively collect the data and also try to implement some translational research in these patients to gain some additional knowledge about this.
Okay.
Okay.
The next question, how common is empyema secondary to malignant pleural effusion, and how is usually the management strategy?
Well, it's not very common, but it's really a major problem if an empyema occurs in a patient with malignant pleural effusion, because the healing is apparently significantly impaired, and it depends a bit on the situation. We first of all try to evacuate the empyema, thoroughly drain it, and probably do some regular flushing of the drainages, and this is the first step to address it. The use of a VAC system, vacuum-assisted closure system, is definitely contraindicated on tumor tissue because it enhances tumor growth. So we try to manage this with a prolonged drainage early on, and we try to avoid a thoracic window by all means. This is always the last resort if there are no other options, but this is definitely something which should be avoided because it's very mutilating for the patient and limiting in daily and limiting quality of life. In very, very few patients it's not avoidable, but usually I would try all other options I've mentioned before first. If we have a patient with an indwelling pleural catheter and which develop infection, we first of all go give it a try with antibiotic therapy, but if it's not possible, then of course the next step would be to remove the catheter and to proceed with some larger bore drainage to evacuate the empyema sufficiently.
Okay. The combined therapy indwelling pleural catheter and talc, is there no higher risk of drainage plugging or obstruction?
We did not really experience a high rate of drainage plugging. It's limited group of patients. Usually it's the upper part of the lung which still have the capacity to expand nicely. We really placed talc localized there, tried not to distribute it too much in the basal part where usually then the catheter is placed, and by this strategy we did not see any increased risk of drainage plugging.
Okay. Okay, indeed, it's important to have two different strategies, I think, and different places in the pleural cavity, the upper part and the lower part. Then another question, are you using the same palliation protocol for both chemosensitive secondary malignant pleural effusion and chemo-resistant ones?
Well, usually the palliation of the pleural effusion is the first step before the chemotherapy starts, and so you don't know whether the tumor will be chemosensitive or chemoresistant. So actually there's no real difference in the management strategy. And I mean, if patients under treatment develop pleural effusions or show some tumor progression, it's always important to reconsider whether a rebiopsy might change anything in the treatment strategy, and some alternative systemic treatments might be available. This is like the case I've shown in the translational part. This is always something you need to reconsider. But otherwise, the management rather depends on the local situation than actually on the chemosensitivity or chemoresistance.
Okay. Any other questions from the audience? Then you're still allowed to ask them during the last minute. I don't think we will have any questions or any more questions. Any final comments from your point of view?
Well, I think malignant pleural effusions are really an issue which frequently encountered. There are still some questions open, I think, particularly for those patients with benign pleural effusions with some underlying malignant disease. Some other internal drainage options might be very beneficial to have available. But for now, with the pleurodesis and the indwelling pleural catheters, I think we have some two good options available, which help in the majority of patients.
Mm-hmm.
There's one more question
Indeed,
coming up.
I see it. What do you recommend in case of excessive and complicated pleural effusion due to restrained heart failure and high morbidity patient where small pore catheter constantly get closed?
So we're talking about benign pleural effusions here. Due to resistant heart failure. Well, I think with regard to the pleural catheters, we only have the catheters with more or less a fixed diameter available. I don't see so many effusions where these catheters actually constantly get closed. But if that's really an issue with regard to the external drainage, probably some kind of pleuroperitoneal shunting might be tried. Or if it's not possible, then some larger drainages might be inserted for a prolonged period of time to achieve a better lung expansion, and probably aim for some pleurodesis with this strategy.
Mm-hmm.
But this can be a tricky situation.
Yeah, indeed. So today we had a great ESTS webinar again. We had over 70 live attendees and many interactions again. So on behalf of the ESTS Learning Affairs Committee, I would like to thank you, Professor Aigner, for the webinar today. The audience, of course, also for your interest and your interaction. And I hope you enjoyed it as much as I did. We will see you back on the 16th of March with Mr. Tim Batchelor from Bristol about enhanced recovery after lung resections. Thanks again, and see you next time.
Thank you very much. Bye-bye.
Bye.